TURNO. So TURNO is a clinical decision support engine for doctors. So unlike TORI was for the patients and TURNO is for the doctors. So let's go through step by step. So for this demonstration, we'll use an imaginary case of let's say a 21-year-old 3 months old a male patient whose body weight is let's say 110 pounds, and he's from United States. And let's have this patient's complaint here. So let's say acute unilateral um, acute unilateral knee pain for 3 days. There is no history of trauma. So that's the patient's complaint. Let's imagine the patient has just come to the emergency room, so there is no PDF file or no image to attach. Right? Let's go to the next step. Now the current treatment is the patient has taken some OTC pain medications. That's all. Uh, Comorbidities, um, no, none of none. Let's just put none. And any drug allergy, again, none. All right. So now let's go to the next step. So this will now load the important questions and the examinations to perform. So the main key difference with the TORI model is that in this TURNO model, this TURNO will actually for the doctors. So it will ask the questions which are more for the doctors, like those are there will be some questions where it might ask the doctors to actually perform some clinical examination and then put the findings. For example, it may ask the doctors to put a stethoscope on the chest of the patient and then tell me what you find. So this model is a little more detailed and more uh, doctors friendly, and might include some medical jargons that was not there in the TORI model. All right. The downside is that this TURNO model is relatively slower because it consults more resources than the TORI models. So TORI model was basically just the architecture. There was just it was just a architecture between um, multiple generative AI models. But this TURNO model is not just the architecture, but it also consults other sources and then find the relevant information into the context. Uh, so let's just wait for the questions to load. Let's give it some time. All right. So the first question is there any visible swelling around the knee? Let's put that for yes. Let's say there is some visible swelling around the knee. Is there redness? Of course, because there will be signs of inflammation, right? Uh, let's let's say there are signs of inflammation. So there is swelling, there is redness. It feels warm to touch. Yes. Has the patient experienced any fever? Let's put that no. There was signs of inflammation in the joint, but there was no fever. Any recent illness or infection? No. Also, let's put that no. Describe the character of the pain: sharp, dull, or aching. Um, let's say it's a throbbing. Let's put something which is not in the option, right? How long does the pain last? Uh, Duration. It has started since few days. No, not yeah, okay. Was the onset of the pain sudden or gradual? It was kind of gradual. Yeah. Does the pain worsen with activity or movement? Yes. Has the patient had any previous knee problem or surgeries? No. So we specifically said that there was no history of trauma or injury. Does the patient have a history of joint problem or arthritis? So not that we know of. Is the patient currently taking any medications, including the over-the-counter or herbal supplements? Nope. Does the patient have any known drug allergies? No. All right. Now let's the recommendations load. So um, again, this will take longer than the TORI model because it analyzes the evidences as well. Now, one thing about these evidence searching is that all the evidences, like including the clinical guidelines and the other recommendations, all the evidence-based sources are for specific conditions, right? So, for example, they can be for disease A, disease B, or disease C. But what happens is that when a patient comes to you, um, it and the case is still not diagnosed with a particular disease, so it might be the patient can be imagined just as a probability distribution of all three diseases. Like the patient is right now as a probability distribution of disease A 40%, disease B 40%, and disease C 20%. So there is no exact guideline for that patient. So what we all can do is that we somehow what we do here is that we create the guidelines on the fly. We create the recommendations on the fly. So that's what we basically do at the back end, and that's what takes the time. And what we try to ensure is that though we are not following any particular guideline, because that is not possible, because every patient's situation is unique, we try to make sure that it is not at least in conflict with some established guidelines or protocols. It's at least it is consistent with the current standard guidelines and the practices. So that's what we do in the back end. So let's just wait for some time, and this will also load. Okay, so this has come, and let's see. So the first differential is septic arthritis, the second was bursitis, and third was cellulitis. So all threes are inflammatory conditions. So given that there was all the inflammatory features was there, right? There was swelling, there was pain, there was redness. So the initial evaluation, joint aspiration, aspiration of synovial fluid for analysis, including cell count, crystals to exclude gouts, culture and gram stain to rule out septic arthritis and gout. So though the gout was not in the differential list, the initial evaluation actually tries to exclude that. So these are the top differentials. It's not that the model considers only these three differentials. These are the top three differentials, but the actual differential list is much larger than that. All right. So the suggested medication is initiating empirical antibiotic therapy for suspected septic arthritis while awaiting definitive diagnosis. Now we know that you know the actual treatment for septic arthritis, as the guideline as per different guideline recommendations, the antibiotic for septic arthritis depends on the result of the culture and gram stain, because it depends whether it is gonococcal or non-gonococcal, and also it depends on what type of bacteria if you find there, right? But when this is still not available, you go for the empirical treatment that covers some broad spectrum of pathogens. So that's what it does actually. It gives ceftriaxone for empirical treatment of septic arthritis to be reviewed after the joint aspiration results, right? And along with that, it gives naproxen as for pain and inflammation, not to exceed 10 days without further evaluation. Investigations. to confirm the diagnosis and to monitor for potential complications, complete blood count, C-reactive protein, and erythrocyte sedimentation rate. Stage 2, repeat joint aspiration if initial synovial fluid analysis is inconclusive and symptom persist or worsen. So those are the investigations. Advice: rest the affected knee, apply cold compression, and elevate the legs. Explanation: the explanation that behind my opinion, okay, the treatment plan is based on the most urgent and the potentially harmful differential diagnosis, septic arthritis, which requires immediate intervention. So that's the rationale. Go for the most serious and the acute condition first. So empirical antibiotic therapy with ceftriaxone was initiated due to high risk of joint damage. Naproxen for its analgesic and anti-inflammatory properties. Joint aspiration is critical for the diagnosis and should precede antibiotic therapy, but given the clinical urgency, simultaneous initiation is justified. So this is what we actually we are doing at the back end. We are, uh, somehow merging all the guideline recommendations, then applying some clinical judgment into it, so that ultimately the plan becomes more practical, right? And can be used in a real life scenario. So blood tests are ordered to monitor for infections and inflammations. And finally, these are the references. So these are the top sources of references, but of course the model has considered a lot more resources than just these three articles. So these are the three top articles that the this model suggests. First is ACR appropriateness criteria, suspected osteomyelitis, septic arthritis, soft tissue infection, 2022 updates. Next is ACR appropriateness criteria for osteomyelitis or septic arthritis, child version, and also the ACR appropriateness criteria, suspected osteomyelitis, soft tissue infection. So basically, all these three are um, actually focusing on the septic arthritis, because that is the most urgent thing here. So let's just go through the link and let's see whether it opens. Right, so this is the first link. uh, while it takes some time, let's also load the other references. This is the second reference, and this is the third reference. All right, so here the first reference, this has been loaded. So this is the ACR appropriateness criteria for osteomyelitis, septic arthritis, or soft tissue infection. Uh, so those are very detailed. So of course, it is not possible that you recommend all these things, but this is just to to refine your plan further, and we have ensured that the guideline is at least consistent with these recommendations. It is not in direct conflict with the recommendations. And of course, it is, again, I want to remind you that there is no guideline for this particular case. There is guideline for septic arthritis, there is guideline for maybe bursitis and cellulitis also, but there is no guideline for this particular case, where the probability of septic arthritis is this percent, bursitis this percent, cellulitis this percent. There is no particular guideline for this. So this is your clinical judgment to how you take the information from different guidelines and then combine them together. And that's what we are doing. We are applying clinical judgment to all the resources and at our backend logic, and we are finally presenting uh, you with a plan that is completely actionable in real life scenario. All right, so that was the demonstration. Thank you for watching.